So we're going to go ahead and I'm going to start. We're still waiting for Dr. Ahmad. So in the meantime, I'm going to do a little welcome and provide some information before we get started. My name is Bill Mejia. I'm the Cancer Support Services Director, and so I've been here since July. And welcome to this great program. We had a similar lecture in September with Dr. Hendricks and Dr. Bischoff. And it was a great success, and we got a lot of feedback that people wanted to come back and hear more. So we have a great panel tonight. And then we also have Allison Sachs returning. A lot of you know her from before me. And so she's here tonight to moderate. So I want to give you some information about things coming up. First of all, this Wednesday from 1 to 4 here in this room, and outside, we have a cancer prevention and screening health fair. So it's good information. We're going to have booths and tables set up, pop-up lectures from different people in various fields of prevention, lung cancer, breast. We have skin cancer. We have smoking cessation, a lot of different programs. So it's available to come, and it's another free event. So that's this Wednesday. Also, I always like to promote the support group that I run. It's the Prostate Support Group, and we meet every first and third Wednesday of the month from 4 o'clock to 5 o'clock. And it's a great group. It's really a good time for people to get together, even spouses, and discuss things that are going on with their current treatments, share different symptoms that are going on. It's a really great way to kind of share with each other, an experience that is what I see in the group is so different for each person. So that's also in your folder. If you would like more information, please, my card is in the folder. You can call me at any time. So the other item in your folder is our March calendar of events. So this is once again not just for people who have cancer or who are receiving treatment, or for survivors. It's for anybody who is experiencing the same. Any people who would like support, maybe who have had cancer or experiencing it. We have a number of activities going on all through the month. So we have these lectures, which we are here tonight. We have about 2 to 3 of them per month, depending on the month. For example, October, we have a number of breast cancer lectures. We just had an evening of caring a few weeks ago. We have lectures on pancreatic cancer, lung cancer, all through the month in the evenings like this, and dinner is included. So please look through this. There's a number of other activities. We have support groups for breast cancer. We also have physical activities such as yoga, Tai Chi, strength classes, strength training. So anyway, those are all there for us, and it's all part of the cancer support services at Lucy Curci. So anyway, now we have Dr. Ahmad here. Welcome, Dr. Ahmad.
Thank you.
And a couple other things too. Housekeeping. So in your folder, we have a statement. It says consent, release, and waiver statement. So back here, we have a video camera that is going to be recording the event tonight so that we could share it with others after tonight. So this is, if you would just sign it, it just gives consent for us. I mean, we're really just looking at the back of your head. So it's mostly focused on our physicians in the panel. So please sign that. And then the next statement is the evaluation form. And we always want to know how we're doing. We love putting on these programs, and we always want to improve what we're doing. So it's important for us to hear what your feedback is, what you liked, what you didn't like, so that we could either improve on it or, do things to make it better. So please fill that out at the end of the program. Okay. So I'm very excited. We're very happy to have a great panel of 4 of our physicians here tonight. So I'm going to introduce each one of them. First, we have Dr. Bischoff. Dr. Jay Bischoff is a board-certified urologist with an emphasis in endourology, robotic and reconstructive surgery. While in the United States Air Force, Dr. Bischoff earned his medical degree at the Uniformed Services University School of Medicine in Bethesda, Maryland, and then earned a fellowship in endourology at the Johns Hopkins Medical Center, Baltimore, Maryland. Dr. Bischoff specializes in robotic, minimally invasive surgery and is trained on the newest generation of surgical robotics, single port robotic surgery. Instead of multiple surgical incisions, single port has only one incision, which affords for less potential for infection and shorter hospital stays, often the same day. Next is Dr. James Hendricks next to him. He's a board-certified urologist and sees patients in Rancho Mirage at the Eisenhower Urology Specialty Clinic. He attended medical school at the Columbia University College of Physicians and Surgeons and then completed 2 years of general surgery residency and 4 years of urology residency at Columbia Presbyterian Medical Center in New York City. Dr. Hendricks practices all facets of urology. He has been doing laparoscopic urology since 2000 and began doing robotic urology in 2002. Next is Dr. Delshad Ahmad. He's a medical oncologist and hematologist. He received his medical degree from Damascus University in Syria, where he also attended a residency program in internal medicine. Once in the United States, he completed a residency program at the Hurley Medical Center in Flint, Michigan. He then went on to complete a fellowship in hematology oncology at Michigan State University, East Lansing. Currently, Dr. Ahmad is the director of thoracic oncology at Eisenhower Lucy Critchley Cancer Center. Then we have Dr. Kamal Patel. He's board certified in radiation oncology and is the medical director of the Eisenhower Lucy Critchley Center Bighorn Radiation Oncology Center. Dr. Patel earned his medical degree from the Chicago Medical School and completed his residency training at Oregon Health and Science University, Portland, Oregon. Dr. Patel comes to Eisenhower from the Cancer Treatment Centers of America near Chicago, where he treated cancer patients since 2007. Our moderator tonight is Allison Sachs. Allison has been an active member of oncology social work leadership, both locally and nationally. She's been the founder of several oncology social work networks, organizations, and certification boards. This includes being the former president of the American Association of Oncology Social Workers. She was the previous director of the Cancer Support Services and continues to work with us on community education programs. I'm always glad to see Allison come back. And so we work very closely together. She really hasn't left. So we're very happy to have you here. So one other thing, as we're going along, there are cards and pens on your table. So if you have a question, please fill out the cards. We found that's better than raising your hand because it helps us listen to the questions better when Allison reads them. So during the lecture, Allison will call out when people have cards, raise your hand and I'll come get them. And with that, I'll turn it over to Allison.
Thank you, Bill. Can you hear me? Am I on? Yeah, I'm on. I have a big voice. I'll drop it down just a bit. Welcome. Thank you all. So pleased to be here. And doctors, thank you. It's been a long day for you. I so appreciate you, as does the audience, for coming after a long day of work and helping us learn and grow together. So thank you for that. Much appreciated. We're going to start right off with Dr. Hendricks. Hi, Dr. Hendricks. Hello. It's good to see you. We're going to talk a little bit about screening and diagnosis to start. I'm going to build up as we learn together different phases and information about prostate cancer. So let's start with screening and diagnosis, which we know is the first step in decision making. And, I really, for me too, want to start very simply, Dr. Hendricks, which is what's a PSA test and how does it help detect prostate cancer?
So PSA is a protein that's made by the prostate. It's useful in that the elevated PSA level increases your risk of having prostate cancer. It's not a perfect test, however, because there's a lot of other things that can cause your PSA to be elevated, such as the size of your prostate, a prostate infection, some inflammation of the prostate.
Could you speak up a little louder or closer?
Oh, okay. Anyway, so it's important. That test is very important for prostate cancer screening, but it's also very important that we do that digital rectal exam be part of prostate cancer screening.
So thank you. At what age should men start being screened for prostate? And is everyone at the same age? Let's just start screening.
I always say the answer to every question depends, and that depends on your family, your history. So people who the general population is generally recommended to start at the age of 45 to 50, right, Jay? People with a African American ancestry, strong family history of prostate cancer, strong family history of other cancers or other germline mutations, then we recommend to start screening at the age of 40 to 45. It depends on what guidelines you look at.
And one of the things to share with everyone that we have heard too, when you talk about germline, that's what you inherit from your parents, those genes, not the genes that make up the cancer, what you inherit, that there can be some connection between the breast cancer gene, the BRCA1 or 2, you use Angelina Jolie's gene, and prostate cancer. So is it if your mom has that gene, maybe you could be high risk for prostate cancer?
Yeah, absolutely, yes. If you have BRCA1 or BRCA2 or any other germline, any hereditary types of cancers, then generally we recommend starting screening early, 40 to 45. It's always good to start 40, we always say, get one PSA and go from there.
Thank you. Yeah, Dr. Bischoff, you want to add some more?
So that's really important. And a lot of people don't realize that. So if you have breast cancer and it was aggressive, your sons are higher risk for prostate cancer.
Right.
Just by having breast cancer, even if you're not BRCA positive. And if you have breast cancer in the female line and prostate cancer in the male line, then your sons are far more likely to get prostate cancer. But it also works for breast cancer. So if you have breast cancer very strongly in the male line in your family, the women in your family, direct descendants of the prostate cancer patients, are much more likely to get breast cancer. And what's interesting is that's not always well known. If you look at, like we do, NCCN guidelines, they change, seems like, I don't know, monthly, but it will tell you in there, if you have aggressive prostate cancer, your descendants should be screened for these other prostate cancer, breast cancer, and vice versa. So take that message home. The only other thing I would add to PSA is just get a PSA. Now, that's questionable if you need a PSA after you're 80 years of age, because you're much more likely to die with it, not from it. But from 40 to 80, we should be talking about getting PSAs.
Yeah. Thank you for that. And thank you for adding that. And for those of you who know, NCCN stands for National Comprehensive Cancer Network. And those guidelines help drive cancer treatments. And they have a great site, nccn.org, but or ncc.org, for us patients. So it's in the language we understand and know, and you can just go on there and click patient information and up it'll come. And it shows you a real algorithm of treatment. It's a great thing to bring to help drive discussion with your physicians. So thank you for that. So we talked about how often now to get a PSA test, but what are normal levels? Dr. Hendricks, when do we start to be concerned?
So first of all, a baseline PSA is a very powerful predictor of prostate cancer. So if you have a PSA of less than 1, it's been shown in a very large study that if your PSA is less than 1 at the age of 60, your risk of dying of metastatic prostate cancer in the next 25 years is less than 0.2%. Given that was in a big population, it's all Swedish people, but the risk is very low if your PSA is less than 1. Generally, a normal PSA is anything up to 3, up to age to 75, the NCCN guidelines state. But it's also very dependent on other factors. The baseline PSA is the most important thing, but anything higher than 3. But then again, I always tell people prostates are like people. They come in all different shapes and sizes. When I ran the New York City Marathon for the first time, I was amazed at how this pear-shaped woman could run faster than I could, you know? But the pear-shaped woman is big and she were a prostate, she'd have a high PSA to start. So a lot of people have higher than 3 PSAs to start with. And so it's more than just the number, it's also their history.
Can a low PSA level completely rule out prostate cancer?
Absolutely not. That's why digital rectal exam is so important. So about 15% of prostate cancers, if I'm right, have a normal PSA. So that's why digital rectal exam is very important in screening for prostate cancer. You got to have a very aggressive prostate cancer, Gleason's 10, which is a very high grade prostate cancer. That's so aggressive that the cells are not normal and they don't express much PSA. So you can have a very low PSA and have a very aggressive prostate cancer.
I'm going to talk some more about screening, right, Dr. Bischoff?
Yeah, just a couple of thoughts about that. What's interesting is if I know that you're 65 and your PSA is 3.5, I don't know nearly enough about you to tell you whether you're safe or you're in serious jeopardy. Because it also depends upon your race, medication you might be taking, and your family history of prostate cancer and your digital rectal examination. So if all I know is your age is in the mid-60s, your PSA is 3.5, your chance of having an aggressive prostate cancer without knowing more about you is between 3% and 60%. So how do we split all of that out? We're working right now with the lab here at Eisenhower to do what's called risk stratification with your PSA testing. So hopefully it'll be done this year. We have all the algorithms that came from large multi-institutional trials of prostate cancer. The main one is called the PCPT trial. It was a landmark study in 2002, landmark study. And what we found out of that trial, the most important thing that came out of that trial is that your absolute PSA value is actually worthless.
Mm-hmm.
If we take it out of context of who you are, what you are, et cetera. So how does the algorithm work? You get a PSA and it prints out on your lab sheet the 16 different categories that you might fall into based on your race, your rectal examination, whether you're taking medication or not. And then you can look and see, and your primary care doctor and your urologist can look and see and say, oh, you know, your PSA is 3, but your chance of having prostate cancer because of who you are is 30%. So now let's have a discussion about that. That doesn't mean we rush to anything. It just means we sit down, we have a discussion about it. Is 30% too high for your comfort zone? If it is, then there are things we do. MRI, maybe or maybe not a biopsy. So PSAs are really kind of tricky. I don't want to bore you with the history, but when this was being developed, they wanted to develop it as a pregnancy test, positive or negative. And it turned out to be far from that. If you have prostatitis, your PSA could be 30. If you're on prostate medications, finasteride, dutasteride, your PSA needs to be doubled. So if you're on finasteride and your PSA is 2, you actually have a PSA of 4 because those drugs artificially drop the PSA. So it's interesting and it's still a very valuable test. So get it until you're 80 and then you probably don't need it.
Thank you for that. So Dr. Hendricks, or Dr. Bischoff, actually any of docs, truthfully, but does imaging help in screening? And if it does, I know we've heard about prostate MRI. Would you talk a little bit about screening, how it's used, when we use it?
Well, that's one of the first tests we do. If your PSA is elevated, then we'll oftentimes, and if we find that you're under all these algorithms that you're a higher risk of having prostate cancer, then generally we'll get a PSA or we'll get a prostate MRI. And one other important thing to mention is also we never jump on one solitary test value. If you get one PSA that's all of a sudden it goes from 3 to 7, we never start doing any other tests until the first thing we do is we repeat it. Because if you repeat it, we'll give it at least a week or 2 after the initial one was done, because 40% of the time it'll come back to normal again, and there's no reason to do any further tests. However, if it comes back and is confirmed to be high, then one of the things that we will go to right away is getting an MRI of your prostate, which will tell us the size of your prostate and also tell us if there's any suspicious lesions that are a higher risk of having prostate cancer.
So suspicious lesions, what's next? A biopsy?
So if you have an MRI that shows suspicious lesions, then generally it depends on, there's a PIRADS category system that goes from generally from 3 to 5. PIRADS 5 lesion carries, 60 to 80% chance of cancer, pretty much. PIRADS 4 lesion is probably like flipping a coin, 50% chance. PIRADS 3 a little less. So with a risk like that, most people kind of want to know if they have prostate cancer. Of course, this also depends on, if you're 85 years old and your parents died when they were younger than you are, then we probably don't really care to do a biopsy. But if we think your life's going to be changed by prostate cancer, then we'd recommend doing biopsies. And when we do biopsies, we do those, they can be done under sedation or you could be awake. And it's very well tolerated these days. We actually target the areas on the MRI that are suspicious looking. We'll biopsy each of those areas a few times, and then we'll biopsy the rest of your prostate at the same time.
Are there different ways to do a biopsy?
There are. The traditional way is transrectal, which is where we have an ultrasound probe in your rectum, and we guide a needle through your rectum into your prostate and take biopsies. So that works well. The problem with that is there's a risk of infection because you're basically pressing stool into your prostate with a needle when you're doing biopsies. It's been well tolerated and we give antibiotics and things like that. But over the last decade or two, we've started doing them transperineally, which is through the skin. So the risk of infection is really zero. So you're not pushing stool into the prostate. We don't even give antibiotics during the procedure. And the procedure is so well tolerated, even awake. The side effects, a little bit of blood in your urine, maybe a little bit of blood dripping out, but there's no pain. There's really, people are afraid of having an invasive procedure done, like a biopsy done, but these days prostate biopsies are so well tolerated the way we do them, and we can do them under sedation too. But that's very well tolerated, and we'll biopsy every single area. I feel like Trump talking right now for some hands. No, but we biopsy.
I don't think you've offended anybody. I'm not sure that's true.
But it's very well tolerated. We'll take we'll do 12 systemic biopsies, and then we'll do 3 or 4 or 6 biopsies, depending on the size of the lesion. So you can have up to 25 biopsies. And when you're done with the biopsies, you feel like something was done down there, but we put about a gallon of anesthetic down there. So you really don't feel very much.
So
Just a
please.
couple, if I might add a couple of things that are important about the MRI. So many years ago, if your PSA was abnormal, we just took you right to a biopsy. And over the last 10 years, the MRI is getting better at eliminating a biopsy. And about 30% of men, because of their MRI, don't need a biopsy. So the MRI eliminates a biopsy in about 30% of men today. So that's exciting. As fun as the biopsy is, that's exciting. Now, the other value of the MRI is our radiologists do a complex 3-dimensional reconstruction of your prostate. So sometimes patients will come in and they say, well, I had a lumbar MRI for my back pain. Let's just use that. But an MRI is like a very expensive Nikon zoom lens, and you only get good pictures of what you're aiming at. And if we're aiming at your lumbar spine, we missed your prostate. So we have to go back and refocus just on the prostate. So then they do a 3-dimensional reconstruction of the prostate. And then Dr. Hendricks was talking about these PIRADS lesion. That's a very strict scoring system that radiology uses to delineate and to characterize abnormal echoes in your prostate. And they grade them on this PIRADS scale, 1 to 5. And so, but then they do a 3-dimensional reconstruction of the prostate. And the reason you're looking at me like, so what, who cares about that? But we are old enough that we used to biopsy men because they had a high PSA and we wouldn't find cancer. We come back the next year, PSA is higher. We re-biopsy, we don't find cancer. They come back 4 years later, PSA is really high, we biopsy them. Now, all of a sudden we find a super aggressive cancer because it was in an area we didn't used to find prostate cancer. Now the MRI does a 3D reconstruction. The MRI is agnostic. It doesn't care where the lesion is. It just tells the radiologist, there's an abnormal spot in this area of your prostate. And the beauty of the 3D reconstructed MRI is there's a new software program that's been out for about 10 years. And it's a special machine called the Euronav, or a fusion biopsy, or a smart biopsy machine. And we can fuse your MRI 3D images with your live ultrasound images. So we put an ultrasound probe in the rectum. We don't biopsy it through the rectum. We biopsy it through the skin underneath your scrotum. Don't do it right now, but when you go home, if you lift your scrotum up and push underneath it, you're pushing on your prostate. No, I said, don't do it right now. Watch him. So we biopsy right through there. The biopsy tells us that when we leave the operating room using the fusion technology, that we can comfortably tell you we hit all the areas that are abnormal. We didn't used to be able to say that. So we biopsied millions of men who had prostate cancer and we just missed it. The beauty of the MRI is 3D reconstruction. They highlight the areas and we can definitively say before we leave the operating room, we hit that spot. That's the beauty of it. So we're missing far fewer significant cancers because of the MRI. That's the value of it. So if you're going to get a biopsy, you should tell your docs you want a biopsy and you want a fusion or MRI directed smart biopsy. In New York, where I just came from, we did all the biopsies in the clinic and the average pain score was 3 out of 10. And here, the equipment that we need is in the operating room to do the smart biopsy. And since the operating room is really close to anesthesiologists, we just give you IV sedation, but it's really not necessary.
Thank you, Dr. Bischoff. So, okay, the biopsy is done. If it doesn't show cancer, Dr. Hendricks, what do we do?
One thing, first of all, one thing to add is MRI doesn't pick up all cancers. And a lot of places, it's important that if you have biopsies done, that you don't have just the targeted biopsies done. But we generally do, with American Urological Association, we recommend doing the biopsies plus 12 sextant biopsies of the rest of the prostate. A lot of people, a lot of places out in public, including in town here, will do targeted biopsies only, and they will not do systemic biopsies. So I'd say 1/3 to 1/2 of the time that we do biopsies here, we find cancer outside of the targeted areas. So if you have biopsies done just of the targeted areas, they may miss prostate cancer.
Really good.
Good point. Very good
Um,
point. Thank you. So no cancer, what do we do next?
Well, then if there's no cancer, then it doesn't mean 100% you don't have cancer, but it means if you have cancer, it's a very small amount and you can safely watch it. And generally, the way we do that is we see you about every 6 months. We get a PSA, take your history and physical, get a PSA, do your digital rectal exam. If things stay stable, then we don't need to go any further,
Wonderful.
you know?
And if you do have cancer, what's next? Further testing or what starts?
Then I think that's Dr. Bischoff's line of questioning, but yeah, then we start talking about, do you need to be treated? And if you do, different options for that.
Yeah, I think that's where it gets hard. Diagnosing prostate cancer is pretty easy. What's hard is then deciding then what. And 30% of prostate cancers today are the kind of prostate cancers that you can safely watch, but they do have to be watched. You can't just walk away from it and ignore it. And there are different ways that we watch them. 30%. Now, one of the requirements for watching your prostate cancer is that you're comfortable with watching. And some men are, and some men aren't. And I've had men over the years who have said, "Oh, I definitely going to watch it. I definitely have the kind of prostate cancer I can watch." And we'll come back to that in a second. And then like 3 or 4 months later, they call and say, "It's all I think about. So let's just treat it." So then we talk about radiation therapy, we talk about surgical therapy. And then I have some patients who are 50 years old and we've been watching their prostate cancer for 10 years. And they say, the only time I think about it is when I have to come back and see you every year. Other than that, I don't even think twice about it. So that's the first thing. The second thing I would add is there's no such thing as one type of prostate cancer. There are many different types of prostate cancer. And that's surprising to some people. But when you're talking about, if you have prostate cancer, there are 3 things you must know. 1, what was your PSA when you were diagnosed? Number 2, what was your clinical stage? And number 3, what was your Gleason score or your Gleason's grade group? That and your age and health status is what we use to decide whether you should be watched or aggressively treated. If you don't know those three things, your PSA, your clinical stage, and your Gleason score, also known as Gleason's grade group, you cannot even begin to compare treatment recommendations with another man who has prostate cancer. So when you're talking to friends, neighbors, relatives, and people at the support group, which we highly support, everybody who gets a new diagnosis of prostate cancer in our office gets a sheet, gets that handout, and we encourage them to go. And when you go, when you're talking to another man who has prostate cancer, the first thing you have to say is, what was your PSA? What was your clinical stage? And what was your Gleason score? And if you don't have the same three things, you cannot begin to compare treatment recommendations. And if you don't know, match up those three things, then your head's going to explode. And you're going to say, those guys, those radiation oncologists, those urologists, they must not know much about prostate cancer, because my buddy John had prostate cancer and they said, watch it. And I have prostate cancer and they said, oh, you need radiation, you need hormonal therapy, and you might need chemotherapy. But we both have prostate cancer. Well, that's true, but you don't have the same type of prostate cancer. You got to know your PSA, you got to know your clinical stage, you got to know your Gleason score grade group. When you have that and age lined up, then you can start to compare. And then it will start to make sense. Until you have those three things lined up with guys you're talking to about prostate cancer, it won't make sense at all.
So it's personalized treatment decisions. So Dr. Bischoff, then what role do genetic tests or biomarkers play in tailoring treatment?
So the biomarkers have a huge role today. It's a long story, but in 1990, I was doing research in prostate cancer at Walter Reed Medical Center with a guy named Judd Mal, who ended up being a big prostate cancer guy. And we were looking at these cancer cells under a microscope, and we were talking all the time about, wouldn't you like to be able to dig out that cancer cell and find out what it's genetically programmed to do? And it was a pipe dream in the 1990s, and now it's real. So for men who are good candidates for active surveillance, we send some of that tissue to a special reference lab. There's several, and they actually dive down, dissect out the cancer cells and look at their genetic propensity to either act like a wolf in sheep's clothing or a sheep in sheep's clothing. And the way we diagnose cancer is by looking at it under a microscope, but that really doesn't tell us what's going on in the cell. What's going on in the cell that made it look like this kind of cancer cell? And now we can dig out the genetics and find out how aggressive that cancer is. It's really an exciting time. And so we have men who want to be on active surveillance. I mean, who doesn't, right? Who wants to rush to treatment? And then we do the test and we find out, you know what, your cancer is actually acting much more aggressive genetically than it looks microscopically. So we want to tell you that watching it's a bad idea. And we have other men who aren't sure, and we do the test and it says, yeah, these tests say, you know what, your cancer is just not that aggressive genetically. So we should be watching. It's really beautiful, a beautiful era between MRI, between smart MRIs, smart biopsies, genetic testing. We just know a lot about it. And we're going to talk about how we're turning prostate cancer into sort of a chronic disease, right? That you might have it and it may never, ever shorten your life. So we have so many treatments now, which we just didn't have.
Well, and first of all, thank you for using active surveillance. You may be reading some older stuff or heard the term watchful waiting. That isn't a term we use in prostate cancer anymore. You're not watching and waiting. You're actively surveying. You're working with your doctor as part of the team, and there are active steps that are taken to track how you were doing. So thanks so much for that, Doc. So how would you describe how doctors balance the risk of treatment side effects with the benefits of treating prostate cancer?
Well, it's simple. If you're more likely to die of prostate cancer, if we don't treat it, you need to be treated. Prostate cancer is a really difficult way to die. And my grandfather died of prostate cancer. My dad had prostate cancer. And so it's only a matter of time before I'll be facing that. And so having that experience in 30 years of treating patients with prostate cancer before we had better treatments than we do now. I'm telling you, it's just a really terrible thing. And we've all experienced that. So we look at you, we'll be very honest, like your actuary does for your life insurance. So when you come in to see us, we look at you through a 10-year window and we say, okay, is this guy likely to live 10 years? And if the answer is no, then we're going to back way off of treating, because even fairly aggressive prostate cancer, if you don't treat it, you live 10 years before it shortens your life. So that's really different, isn't it, than other cancers that you're familiar with. And it's hard in our mind to separate pancreatic cancer, prostate cancer, stomach cancer, but prostate cancer is a totally different beast than all the other cancers that you can think of and name right now. So truly, even in fairly aggressive prostate cancers, you don't do anything with it and we caught it early, you're not going to die for at least 10 years. So we look at you through that window. But if you come in and you're 60 and healthy, 50 and healthy, or 70 and healthy, and living here in the desert for the last years has taught me a new definition of aging gracefully, because I guarantee you in New York, if you're 90, you didn't drive yourself to the clinic, right? Somebody wheels you in a chair. Here, 90, I see a 90-year-old every day in clinic, and they're mad if I'm 5 minutes late because they got a tea time or they're playing cards. Or that's different here, but we look at you through a 10-year window. And if you're not going to make it, if we don't treat your prostate cancer, that's an easy decision. We need to treat it. And then all of the side effects, we need to fix them so that you can have a good quality of life.
So one more question for you, Dr. You make it so easy. Thank you. What are the main treatment approaches for localized prostate cancer? Just the main treatment approaches, and how does a patient choose the best approach?
It's hard. It's a long discussion. Radiation, for most types of prostate cancer, the chance for cure with radiation is the same as a chance for cure for surgery. So you have to talk to your surgeon, and I recommend all my prostate cancer patients go meet with one of our radiation oncologists. Some have already had it in their mind they don't want surgery. They want to go right to radiation. Some of them have it in their mind they want surgery, they don't want radiation. And then some of them are in the middle. But I still, even the guys who come in and say, no, I'm just here to get surgery scheduled, I really encourage them to go talk to a radiation oncologist to find out what are the different side effects from each form of treatment. And so we have that. And that's about an hour discussion. That's not a quick discussion.
Thank you so much. Before we move on, thank you both of our urologists. If you have questions, remember, write them down and just hold it up and Bill will come and pick them up from you if you would use those index cards, but we'll take a paper if you have one. That's fine. Thank you so much. I really appreciate that, both of you. It was very interesting and helpful. Hi, Dr. Ahmad. It's nice to see you. We're going to talk a little bit now about treatments and advances in metastatic prostate cancer. We kind of laid the groundwork for prostate cancer, what it is, how do we find it, what are the tests that we do, what are some of the treatment options for localized prostate cancer, the questions you should be asking, what you should know, and thank you, that was incredible. But prostate cancer can metastasize, it can move. So let's talk a little bit about that. And let's start as simply as, what does it mean when prostate cancer is metastatic?
Yeah, so metastatic means that it has spread to a different organ or structure. So most commonly, really, it is either the lymph nodes or the bones. And it can go to other organs too, such as the liver or the lungs. Those are the most common. They can go anywhere really, but the most common ones is the lymph nodes and the bones. So when we say spread to those, usually you have to do some scanning to look into those. Sometimes even when the patient go for surgeries, incidentally, we see lymph nodes, but generally this is done before deciding for what the patient will do. Are they going to go for surgery or radiation? Most commonly, especially if they are on the higher level of the scores, unless they are very low score, you don't need to routinely do imaging or scans to find out. But if there is, usually you do scan to see it is not spread, then do surgery or radiation. But if the scan showed really that it is spread to one of these organs, that's what we call it metastatic or stage 4. And that's where really the treatment become not we cannot cure it, but we definitely have a lot of treatments to control it for as long as we can, based on what and how and where is it spread.
And if it does move to, say, bone, which seems to be the most common or more often with prostate cancer, it doesn't become bone cancer. It's still prostate cancer that's moved to the bone, correct?
Yes, so
Okay,
we
thank
call
you.
it that you still have one cancer. It's not two cancers really. It's a prostate cancer that's spread to the bone or the liver. Like you only have one cancer.
Are there symptoms to watch for thank you so much, Bill. Are there symptoms to watch for with metastatic prostate cancer, something to be aware of?
I mean, definitely, unfortunately, they are not very specific, but definitely most cancers, when it depends on where the spread is. So if the spread is to the bones, then it might cause pain in these bones. If it's spread in the liver, you might become jaundiced, or if you spread to the lungs, you might get short of breath. But it depends really on what organ the cancer has spread to. But most commonly are the bones, as we mentioned, and the lymph nodes. And one serious one is really if you have like some back pain or anything, those are the serious ones, especially if you develop like sciatica or nerve pain. That's where we have to be very careful that there is no pressure on the nerves or the spinal cord.
So one of the things we often hear about, and it isn't just with, and I know we'll talk about with radiation too, Dr. Patel, but we're here often about is androgen deprivation therapy, ADT, or hormone therapy. Is that something that's used in metastatic prostate cancer?
Yes, it can be used in both situations. Actually, it can be used in early stage, prostate cancer, and when it's spread too. So, as doctors said, when it is localized, really, it gets subdivided into multiple categories based on the criteria we mentioned, and then some of those still need the androgen deprivation therapy, even though that the cancer didn't spread. Once the cancer spread, that's really the backbone and the first thing that we do. And what we call it androgen deprivation therapy is meaning you're trying to lower the testosterone level, because that is technically the driver that is making the cancer cells grow and spread. So we generally make the testosterone by some hormones coming from the pituitary gland and going to the testicles, or making hormone making the testosterone, or in some other organs changing some of the other hormones to testosterone. But the main one is really usually trying to deregulate or make changes in the way that this hormone from the pituitary gland gets created, and that blocks the production of the testosterone, and that really keeps the cancer food away. So that helps to control the cancer longer time.
And I thank you for that. I recently read that a single drug to suppress testosterone production is no longer the standard of care. It's more other drugs in combination for any of you, actually, Dr. Ahmad, or are there guidelines to this at this point?
Oh, definitely. Yeah. I mean, the main thing is still the androgen deprivation. For the localized one, it's still mainly the same one. It is different ways of doing it. It's either shots or pills. But once it is spread, actually now we don't do only lowering the testosterone. We add a different ways of adding medications to, as we mentioned, it's not only the production, it's also there is conversion of the other hormones to testosterone. So we add medications to even really decrease the production from other organs, such as fat tissue. There's conversion from other hormones to the testosterone, and we add those medications. And actually now that is the standard of care, is when you are metastatic. We used to only just suppress the testosterone production, and that gives more. Now since we're getting more results, and they are fairly reasonably tolerated, now we're using more later medications that we used to do after the cancer getting worse. We start using them from the get-go, and really those depending on more detailed evaluation about how the patient is doing, what's his general health, and more discussion about what do they prefer to start with. But yes, now technically the standard, if the cancer spread, is not only lowering the testosterone, there is a lot of group of medications that we add, what we call them the anti-androgen, that even if there is some trace of the hormone, we block that effect on the cancer cells.
Thank you for that. And at some point, does hormone therapy stop working? And if it does, what are next steps? Is that the next step, the chemotherapy?
I mean, that the chemotherapy is part of the treatment, but it is really depending on when and what happened and what the treatment was the patient getting before. And I mean, our main challenge with cancer is that the cancer cells change itself. So it finds a way to run away or make different ways to proliferate or make new cells. So generally, they all most commonly respond for some period of time. After a time, it depends. For some patient, it can be 6 months. For some patient, it can be few years. This cancer cells adopt to being low on testosterone and find other ways. And that's where the other treatment options come into role. And at that time, we call it that they are not hormone sensitive anymore, meaning, before initially they were hormone sensitive, meaning the main way of getting or staying spreading or alive cancer cells, if we call it, is the testosterone, versus after that, really they depend on different ways. We call it castrate resistance. So when the main thing is really that the hormones is working, we call it hormone sensitive. Once the whole anti-hormone doesn't work alone anymore, we call it castrate resistant.
So I know we could do a whole presentation alone, Dr. Ahmad, just on things like targeted therapies, like PARP inhibitors or, immunotherapy. Is that used in prostate cancer? But for a brief overview, are there targeted therapies right now, like PARP inhibitors for prostate?
Yeah, I mean, definitely. I mean, the whole area of all cancers, really. Now, as we mentioned, in addition to doing the genetic testing, that's what we call this really, if you have anything germline, meaning if you have any genes that predispose the patient to the cancer, and there is the genomic testing, which is really testing the DNA of the cancer cells. So few percentage of prostate cancer patients, as we mentioned, that's why we screen them. Even for early stage now, we do genetic testing for almost everybody, if they are intermediate grade or more for sure. And that definitely gives us more options for treatments. And those genomic testing, if some of them, yes, we find this mutation, such as the one that you mentioned, the Angelina Jolie one, or the BRCA or the BRCA1 or 2, then they are candidate for a lot of easier treatments compared to chemotherapy and working for a long time. Those still comes with some side effects, but they are definitely more easy to tolerate compared to chemotherapy. And one of those is really what we call it, the PARP inhibitors. They work directly on the DNA of the cells, is not really stable as the usual cancer cells. So it's easier to really destroy the DNA of this cancer cells. In addition to that, really, there is something what we see all on TV, like Keytruda or other immunotherapy regimen treatments for other type of cancers. That's also, some of this can be treated like that. But again, not everybody is eligible to get one dose. So you really have to test the cancer cells. And then again, it is becoming more personalized, really, based on what you see on the cancer cells, what is the best option to start with, and what is the later options. And we always keep in mind really what is the quality of life. So, that is a very, very important goal for us, because now we know that we cannot cure this cancer. We're trying to help the patient to live as long as we can. And it's really not worth it to live miserable, but we just extended your life a little bit. So the main focus is to keep that balance, and that balance, you really start with what fits this person based on what possible issues could come with this a medication. So some medication, let's say if somebody is diabetic from the get-go, I don't give them some treatment. I usually start with something else. If they are not, I prefer that. So it's really, you look at the whole person and the whole genomic testing and how much is the cancer spread, what is his age, what are the expectations, and then you decide really what's the first and the second and the later treatment plans are.
Thank you. I've been reading, I didn't understand this, I have to be honest. I've been reading about radiopharmaceuticals like Pluvicto, which is also lutetium-177 PSMA therapy. And it is used, I believe, right now only in metastatic setting. Would you explain what it is for all of us?
Thank you. No, I mean, definitely, as in all areas of cancer, really, there's been significant advancements in the treatment of prostate cancer. And that is one of them is really what we call it PSMA. And that's kind of becoming more of standard of even scanning the patients to seeing how much is that spread. So technically that looks into a specific receptor on the cells that really tells us, where the cancer has spread to. And if that is positive, that gives treatment option, that what we call it, the Pluvicto. And that is, as of now, it is really approved for later line of therapy, but definitely there is more trials being studying as we learned how to bring the later ones sooner. Now there is studies looking into really if we should start that sooner. It's definitely generally easier than chemo. It still can, I mean, there's no medication without issues, but generally reasonably easy compared to what we call it standard chemo. And it has great results, and hopefully we'll have that done sooner in the future once we have more results from the current studies.
Thank you. Please.
I'd like to can you guys hear me?
Yeah.
Well, thank you for this great turnout and thank you for having me. Pluvicto is one of these radioligand therapies. And so for a radiation oncologist, this is kind of the holy grail. It's like a heat-seeking missile that goes and finds the cancer. That's the first part, the PSMA. And then it's attached to a radiation particle that kills that part of the body or the cell. So it's a heat-seeking missile that attacks directly at the cancer. And in this case, it's prostate cancer. So it's one of the big advancements we've had in medicine and in especially prostate cancer. This is just the beginning of many different options that we're going to see, not just for prostate cancer, but in oncology as a whole. But that's the way I kind of look at it. Radioligand therapy, Pluvicto, it's really able to seek right where the cancer is and attack right at the cancer.
Thank you, Dr. Patel. Dr. Ahmad, is there anything I didn't ask that I should have in the metastatic setting at this point?
No specifics really. I mean, there's a lot of medications. All what I say, really always be aware of what you're getting treated for and what medication you're getting and what are the benefits and the risks from that. And I mean, mostly most patients go through most of these lines of therapies. It's the matter of how you start one or do the others. And definitely, as always is mentioned, the genetic and the genomic testing in these cases.
Thank you. And I want to, as a social worker, I can't help myself. I want to remind everyone, Dr. Ahmad said a lot of very important things, but something really stuck with me. He said it very quietly almost, but all treatments have side effects. You see these commercials on TV and these cancer patients they're laughing and they're having dinner and it misleads us sometimes. And then we're like slammed with, why do I feel this way? It doesn't mean they're all awful treatments. There's all kinds of levels, but every treatment has some form of a side effect, and ask about that. So thank you.
They are definitely easier and easier though. So
Yes.
still, yes, but there is no medication. Even if you read, I sometimes say about Tylenol or ibuprofen, it can cause major issues.
Right.
We're not saying our treatment is like Tylenol, but definitely there is nothing without side effects.
Thanks, Dr. Ahmad.
Well, to go to Dr. Bischoff's point about active surveillance, even that has side effects, right? The anxiety of the patient or potential of the cancer to spread. So even doing nothing could potentially have complications.
Absolutely. So perfect segue. Thanks, Dr. Patel. We're going to talk about radiation therapy innovations and some advancements and what's going on. And I think I'd like to start, if it's okay with you, so just some basics, and how has radiation therapy advanced and when is it recommended over surgery?
Great question. We have 5 hours to.
I know, sorry.
So I think many of you guys probably know what the cell phone looked like in the 90s. You used it to make calls. And nowadays, the cell phone is completely different. Most people probably use it for a lot of other stuff than making calls. But just as the cell phone has advanced over the last few decades, just the same thing with healthcare. I'm sure surgery, medical oncology, in our field. And it's a very exciting time to be in healthcare because there's so many innovations that have happened even within just the last few years. But the next 5 to 10 years, it's going to be exponential. And in terms of my field, it seems like we used to have like the cell phone of old. And now we have the modern, latest and greatest iPhone, where you have incredible technology and capability that we didn't even think we'd be able to get to. There's still, of course, opportunity for us to help our patients, but that's one of the exciting things about being in healthcare, especially as a physician, is there's so many new things, and every day there's something new coming out that could dramatically change how we kind of guide your care. So maybe tomorrow something comes out and the discussion we have today might not be as valid as it is going into the future. Now, the good thing about prostate cancer is there's a lot of options, and that's why you see us doctors here. Unlike many of our patients that may have only one option or sometimes 0 options, for many prostate patients, they actually have multiple options. And that's a good thing and a bad thing. It's good that they have multiple options, but it can cause a lot of stress, anxiety, confusion about what they should do. And I think our physician team had spoken that really it's a personalized decision. And we take everything into account for that patient. So I think Dr. Bischoff did a great job saying, well, first you have to divide the patient. So just because your friend, brother has prostate cancer, they're not all the same. And even sometimes, very rarely, but sometimes patients do a Dr. Google search and they'll be like, hey, Google told me to do this, where obviously there's a lot of misinformation on the net. So first thing we do is we do go through the national guidelines, and they do change quite often. They help us as physicians to see how can we make sense of each patient? What bucket or category do they fit in? And that gives us kind of a general overview of where patients are, so they can be localized or metastatic. Within localized, it's a continuous spectrum. Even within metastatic, we're realizing it's a continuous spectrum. And even though your numbers might be similar, there's a lot of other factors besides just the basic ones of the PSA, the digital exam, the Gleason score that we look at. The MRI is extremely helpful for us in radiation oncology because it helps to guide not just the question between surgery and radiation, but even within radiation, there's so many different options that are available to our patients that how do we figure out what's the best one for each patient? And so as we gather all this information, we're able to personalize that recommendation for that patient. But overall, the good thing is for most localized prostate patients, as was mentioned, there's 2 kind of equally curative options, surgery and radiation. And we can go into further discussion after.
Yeah, a little bit. Thank you for that very much. A little bit. There are different types of radiation. I know there's, and they always have these acronyms, and I always have to write myself little notes to remember as I'm talking. EBRT, which is external beam radiation and IMRT, intensity modulated radiation. How am I doing so far, right?
Great.
And SBRT, stereotactic body radiation. And then we could talk about seed implants as well, not as popular as they once were, et cetera, et cetera. But what's the difference between all of these?
Sure. So we've been using radiation for prostate cancer almost since it was introduced over 100 years ago. And they actually did internal radiation. They've done external radiation over the last 100 years. The way I break it up for patients is there's 3 ways to look at radiation treatment. There's external radiation where a patient comes in, lays on the table, and the machine treats them for a few minutes. Internal treatment where we'd have to do a procedure to place some catheters in the prostate. And then we just discussed radioligand therapy. That's like an injection that you're given, kind of like other injections you might get. But this injection vial is filled with radiation particles. And the radioligand therapy is like those heat-seeking missiles. So the basic way to think about it is there's internal radiation, which is brachytherapy, which we can talk more about later. External radiation, which we'll talk about in just a minute, and then the injections. So for external radiation, there's a couple ways to do it. Broadly speaking, here and almost everywhere in the country and world, we use a particle called X-ray. And X-ray you guys have exposure to because if you go to a dental clinic, if you have any type of body X-rays, that's the same particle we use. Ours is just a much higher energy. And then in the 1990s, Loma Linda actually had the first proton radiation facility. And it's been up and running since the 1990s. That's a different particle of radiation. There's only about 45, 50 places in the United States that have proton radiation, but that's a different particle of radiation. So broadly speaking, within external radiation, there's X-ray radiation and proton radiation. Now, when you look at all the studies over the last 30 plus years, the data would suggest that they're equivalent. So whether you do proton radiation at Loma Linda or you do the radiation that we have here, X-ray radiation, the outcomes are equivalent. And I think part of that is for X-ray radiation, the exponential advancements we've had over the last 20, 30 years have offset the theoretical advantage of the proton. So on paper, protons look fantastic. And you would think, why would they ever be at a disadvantage or show equivalence when you're doing a head-to-head study or just looking at different outcome studies? And over the last 35 years, because I think our X-ray radiation has had such significant advancements, and I believe we'll talk about those in a little bit. The great news is we're able to do incredible care that's equivalent to proton radiation. Now, having said that, we do have affiliation with UC San Diego, and they do have a proton center that's available for our patients. Now, the good news is UCSD proton machine is actually a much more modern machine. The Loma Linda one is an option. It's much closer, but it's 35 plus years old. The one at UCSD is a much newer technology. And I think at some point in the near future, we'll have kind of a discussion just on that. But overall, for external radiation, we do X-ray radiation. And within X-ray radiation, if I were to have spoken with you guys 5, especially 10 years ago, there was only really an 8-week course option. So that's where you come in once a day, about 10, 15 minutes a day, Monday through Friday for around 40 treatments. So that was the 8-week treatment. And over the last 10 years, we've had so much more data that says you can do an 8-week course, maybe a 6-week course, a 4-week course, and a 2-week course. And they're all considered standard of care as of today. So we have just a great amount of data. Now, that doesn't necessarily mean every single prostate patient will be eligible for each of those treatment options. That's where looking at everything in terms of your specific factors comes into play. And based on that, you may be a great candidate for one over the others, or you may be a great candidate for all of them.
So is the image-guided radiation therapy the one that becomes so pinpointed radiation to spare that tissue, radiation that shouldn't be radiated?
That's one of the big advancements that we've had is, I'm sure many of you have had CT scans in the past. And one of the big advancements in our field is we actually now have a CT scanner built into the machine. So before each treatment, we're actually able to do a scan and make sure that we're pinpoint spot on the prostate. And only when we're absolutely sure that we're treating exactly what we want to treat will we beam on. And there's additional things we can add to make that process easier. There's something called gold fiducial markers, which our urology colleagues can place to make that step easier. There's actually a spacer that can go between the prostate and the rectum to push the rectum a little bit out of the way. So there's a lot of advancements, but also going from 3D to IMRT, where you're able to do just very pinpoint focused treatment, has been an incredible advancement in our field.
Thank you for that, Doc. That was amazing. So how does radiation therapy fit into treatment for metastatic prostate cancer patients, those whose cancer has moved elsewhere?
So in the 1990s, I believe, there was this wild theory that not all metastatic patients are the same. So up until maybe 10, 15, 20 years ago, there's really only two categories of patients. There were localized curable and metastatic uncurable. And one of the big things that's happened is, as our systemic therapy options, the treatments that Dr. Ahmad is able to do have gotten better and better, local treatment and its role has become more and more important. So now there's 3 categories of patients. There's the localized curable, there's the widely metastatic, still considered uncurable, but you can still treat them and it can turn into more of a chronic disease. But then more recently, we have this terminology called oligometastatic disease. And that's not just for prostate cancer, it's for pretty much all cancers as a whole. And there's a few different definitions, but this is either when you're diagnosed, you just have up to 5 sites of metastases, or it could be a patient that had metastatic disease. Now there's only like 1 or a few spots that aren't behaving. And over the last 5 to 10 years, for us, that's been the biggest growth in terms of data, and the patients we see are these patients who have oligometastatic disease, and now they're coming for an opinion for radiation treatment. And the exciting part is when you look at the data for prostate cancer and also beyond prostate cancer, what you see is these patients could potentially have long-term cancer control or cure. So that was something that we would have never thought of or didn't think was possible, but it actually started with GI cancers, and really in prostate cancer, there's great data. So for us, that's the biggest amount of data that's building up, is in these patients who have kind of small volume metastatic disease, and that local treatment plays a very important role for long-term success.
Well, thank you, Doc. Is there anything I didn't ask or that we should know about? Anything new coming down the line that you didn't mention? Any clinical trials that are happening?
Well, I think there's a lot of different things that are being studied. Of course, you guys know in general, there's a lot of AI that's coming into medicine, a lot of new systemic treatments, the radiopharmaceuticals that I mentioned to you. There's, of course, through UCSD, they're one of the biggest and most respected cancer centers in the world. And so we have a lot of opportunity for clinical trials through them as well.
Please.
There's a brand new clinical trial that's going to come online soon. And by that, within the next month or so, and it's a trial for our active surveillance patients. So there's really good data to suggest that high doses of green tea could help slow prostate cancer down. So, but it's really high doses in a capsule, and you have to get it outside of the United States. So there's not enough green tea you could drink that would do this. But so don't just go out and buy all the green tea at Costco. So, but it's a very interesting study. It's a randomized study. So some patients will be on the high dose, some will be on a placebo. The doctors won't know, the patients won't know. And that's the truest kind of study you can do. We call that a double-blinded placebo-controlled trial. Those are pretty rare in prostate cancer, but this is in an active surveillance population. And we're going to be offering that. So if you are on active surveillance or you know somebody who is, please contact the cancer center and say, hey, I want to be involved in that new green tea trial.
You know, you do your evaluation forms, write that down and write how we can contact you. And please cross your T's and dot your I's so we can read them, close your zeros, you know. Otherwise we look at it and go, we don't know what this says. This was extraordinary, really, and we have some great questions and we have time for them. I remind you again, after our last presentation with Dr. Patel, if you have any questions, to hold those up and Bill will come around and grab them, or you can just hand them to me if you want. We're that informal, either way. I do want to remind everyone, and Bill mentioned it beforehand, and he is my boss. I'm just letting everyone know that he is my boss. So I'm acknowledging that he did already mention this, but I want to reiterate that every one of these doctors in one way or another mentioned quality of life. They mentioned care for the whole patient. And that's extremely important with any cancer. I, in my years of work, have found it extremely so in prostate cancer, where there are often for you multiple choices. You know, it's not uncommon to hear someone walk into a support group or, you know, sit down and go, well, I didn't go to medical school. How am I supposed to know what I'm supposed to do next? It can be very overwhelming, and every one of these physicians acknowledge that. Bill's programs at Lucy Curci Cancer Center are extraordinary. I mean, Dr. Patel has a designated radiation oncology social worker just there to work with patients. There are nutrition counseling, there is nutrition counseling available. There are stress management classes, there are support groups, there are these lectures. We really encourage you to take advantage of that, and all it is free, thanks to our donors. So we also encourage you to be donors at all times, at any level. And I think that's really important. We have the latest and greatest machines. Donors paid for those. We have the latest and greatest yoga classes. Donors paid for those. That could be a $5 donation. That could be a $5 million donation. It's all the same thing. It's about care in our community. So please don't forget that. I'm done lecturing. I'm going to do questions now. One of the first questions is the gentleman gave quite a bit of history, which we're not going to go into. Again, we're not doing consultations here. That would be inappropriate. But he was saying, well, at his age, when he has a rising PSA and a large prostate, and he's followed DREs and PSAs every month, and his doctors are monitoring him, active surveillance. But his question at all of that is, what does it mean for his children? As far as monitoring, screening, and I think we touched on that, but briefly again, Dr. Bischoff, perhaps.
Yeah, so it depends on your Gleason score. if the aggressive cancers that have a genetic propensity are Gleason 7 and higher. So if you're just watching a small amount of 6, your kids are safe. If you have 7, 8, or 9, or 10, then your kids should be checked. Your boys should be checked starting the age of 40. That's the answer.
Thank you, doctor. I'm not sure who to address this to. What's the latest update with ultrasound ablation as a treatment for prostate cancer? And I've been thinking HIFU do you think that's what HIFU, which has been around a long time and it kind of seems to do this circle. Would someone take that about HIFU and what do we think about it right now?
I mean, HIFU, it's an option that's out there, but it's focal therapy and it's still experimental. So we don't typically do it here. Actually, we don't do it here.
Right.
But it's not really part of the guidelines that I know of.
Yeah, it's real interesting because we've been doing HIFU somewhere in the world for 20 years.
Yep.
So let's explain what it is. It turns out that everybody's familiar with ultrasound, and we say, you know, if you get an ultrasound, nothing bad happens, right? But you can use what are called acoustic mirrors and focus ultrasound waves so they damage tissue, creates high heat. And so 15 years ago, I went to the Bahamas, not for vacation. This was totally work at the Atlantis Casino because in the Bahamas, they were doing HIFU at great volumes, and Americans were just flocking there. And Blue Cross North Carolina would pay for you and a partner to go get HIFU prostate cancer treatment. They cover everything, your expenses, you stayed at, and we were really impressed. You put the ultrasound probe, you general anesthesia, and they shoot these high frequency ultrasound waves, and it kills tiny pieces of the prostate. And they were doing it in Germany almost 8 years before that, but it just hasn't caught on. And the reason it hasn't caught on is because a lot of people fail that treatment.
Right.
So people go there thinking, well, you know, it's going to be fantastic, no problems. There are complications associated with it. But the problem is it's not working very well for prostate cancer. It works really well in the low-grade prostate cancers, but those are the ones that may not to be treated. So that's the HIFU treatment. Also, if you have prostate calcifications, the ultrasound hits the calcium and it doesn't get through the prostate. And if you have a big prostate, there's a limit as to how big of a spike of tissue damage you create. If you have a big prostate, they can't get all the way through the prostate. So HIFU is still considered to be non-mainstream. And if it was really amazing at treating prostate cancer, it would be totally mainstream. It's not new. And those things that aren't new, that haven't really caught on and done away with surgery and radiation, there's a reason for that. And that's because they're less effective.
Thank you.
What else would you guys add to that?
I don't know. I could just add, like, I think not only that, I always encourage really to depend on a source that is good when you read and when you look into your options. Because, you know, it's like you could see news on Facebook and you could see news on CNN or Fox or whatever channel you like. What I'm trying to say, you have to really depend on a good source. And that's what we mentioned, the NCCN guidelines, because quite often we get these questions. Okay, what about if I eat this thing? What about if I tried to this? What about the sugar? So there is a lot really on Google, you know, or on the net that what you could see. But really, for us to recommend specific thing, we should have not only a study that is done. It has to be a high level study through good an investigation to how much this help and what are the problems to decide that. And that really apply to all aspects of the treatment for this cancer specifically, or all cancers. So I wouldn't just really get attached to one thing by itself just because I saw something small about it, which we see quite often, that patient get attached to that and they don't like the whole treatment or what's happening.
Thank you, doctor. And really good resources for you. Of course, is the American Cancer Society, cancer.org. Zero Prostate Cancer is also it is the largest non-governmental organization that advocates and educates in prostate cancer. Michael Milken's group, Prostate Research Foundation, PCRF.org, zero.org. American Cancer Society, all of these places have really excellent, up-to-date, verifiable information. They are not selling you anything. They don't want to treat you. They want you to be educated and informed. And I think that's very important. In June, we are looking to provide a wonderful presentation on paging Dr. Google, finding information on the internet. And I'm going to brag about that till kingdom come, because I'm going to do that presentation for you. And it will cover everything that goes on the internet and how do you sidestep it and how do you get good information. So thank you for bringing that up. What medications affect PSA screening? What should what should they know about? Are there certain medications? I mean, that's a big question.
Well, the biggest ones, obviously, there's medications that you can take for BPH that shrink the prostate, such as finasteride and dutasteride. And like Dr. Bischoff said, when you take finasteride or dutasteride, it generally shrinks your prostate by about 1/3 to 1/2 the size, which also means that it'll make your PSA go down by about half. So somebody who's on those drugs will generally take their PSA, will multiply it by 2 to get what their true PSA is. Other than that, medications, I mean, if somebody has, in the old days, we used to treat high PSAs, we used to give people antibiotics. People used to always try, I'll just give them a month of antibiotics because they might have a mild infection. And sometimes you see the PSA come down, but not always. But sometimes if you have a mild prostatitis that you just don't know you have, that can make your PSA go down. Turns out there's no other real class of drugs that I know that will lower your or change your PSA.
No, and then there is the whole thing about activities, sexual activity, cycling. I just talked to the AIDS group, with prostate cancer, and I did a literature search on receptive anal intercourse, and there's no data on receptive anal intercourse and how much it raises your PSA. So in general, abstain from sexual activity of any type for 7 days before getting a PSA.
We could do that study here.
We could do that study
Yeah,
here.
for sure.
Um,
They also are asking doctors,
Yeah.
and I believe it should be on your biopsy report, how to get a Gleason score. Is it on your biopsy
It is.
report?
Every biopsy report has Gleason score. And because Gleason score was a little bit confusing, we're now moving towards Gleason's grade group. So your biopsy report will have a Gleason score, and it will translate that into Gleason's grade group. So it's essentially the same, but it's less cumbersome. Gleason's grade group. It's on every biopsy report. If you have cancer, and if you don't, it will just say benign.
There we go. Thank you. Gentleman is asking, and by the way, your age has nothing to do with these side effects for whether you're 93 or 63. Having side effects for Lupron and bicalutamide, hot flashes are killing them, no energy, muscle pain. This is very common side effects. Would you address some of the ways to cope with those?
Yeah, I mean, I know, with the medications, really, unfortunately, there is no rules to know who will have what. But, you always have to try and see, especially with the Lupron or the anti-androgens in general. Most of the symptoms are usually mild, and there is some medications to help with this possible side effects, including hot flashes. But they are definitely some issues with other things such as aches and fatigue and mood changes. Reasonably still not too much compared to chemotherapy, but there is the side effects. Usually it's not majorly related to the age or specific other disease. It's really how do you respond to that medication? And I always try to say, you might get a headache. We both say we had very bad headache. You take half Tylenol, you're fine. I take 2 Tylenols, I'm not good. So our bodies are different, even though we have same age, even though may have same cancer, it's really different. So we really don't know until we try and see. But anytime really you have any issues from any treatment, I will definitely discuss that with my physician and see if there is any ways to alleviate those, or at least to get some medications to help to control the symptoms.
One
Thank
of the
you.
things that we're anxious to get started here as part of survivorship is a clinic for our patients on hormonal therapy, androgen deprivation. There are treatments for the hot flashes. And if your partner is female and about your same age, you will not get any sympathy from them.
That's correct.
So come and see us. And
That is
you'll get
correct.
sympathy from us, and there's some medication we can help. It'll help dumb those down so they're not so exaggerated. Watching what you eat and weight-bearing exercise and anaerobic exercise is crucial, because the androgen deprivation also causes weakening of bones and predisposes you to fractures. And so weight-bearing exercise, anaerobic exercise, cycling, walking, and food management, and then medication to help with the hot flashes is crucial for that. We'd love to get a survivorship program just for androgen deprivation.
Great
patients
idea.
here.
That's a wonderful idea.
we-
And again, Dr. Bischoff stated, we have, if you are treated by an Eisenhower physician, then we have nutrition counseling for you. That's important. We offer strength training with staff from our physical therapy, occupational therapy staff. We don't want you, if you have metastatic prostate cancer, we don't want you going to a gym with a very well-meaning trainer who goes, give me one more rep, you can do it. We would prefer that you are in a class with someone who understands what it means to have metastatic prostate cancer and how you can train safely. We have yoga classes. We don't get on the floor in a pretzel. You can sit in a chair. It's really strengthening and stretching. So a lot of good programs. Thank you, Doc. What's free PSA? Someone wants to know. What is it free as opposed to a not free PSA?
Free PSA, the PSA is bound by proteins. Part of it's bound by protein. Free PSA is the part of the PSA that's free floating in your serum or your blood. So it's not really important unless your PSA is usually between 4 and 10. And if the PSA, your free PSA is low, if it's 15% or lower, then your risk of prostate cancer is higher. If it's higher than 50%, especially over 20%, then your risk is lower. It's just another thing that we look at in screening for prostate cancer.
Thank you. Any risk of cancer escaping because of the biopsy? I believe that's that term seeding that sometimes can happen with certain biopsies. Does that happen with prostate cancer, where if you put a needle in and pull it out?
Go ahead. Shreya, story.
I'll tell you, there are certain tumors that if you biopsy it, you're going to seed the tract. Bladder cancer is really good for that. Gallbladder cancer, really common to seed the tract. You pull the gallbladder with gallbladder cancer through a trocar site where you're taking out the gallbladder and you don't know how to cancer, you're almost always going to grow there. What's interesting is that we biopsied people through the rectum for 30 years. And I don't ever remember in 30 years seeing a primary rectal cancer arising from biopsy, even though we know that we drag prostate cancer cells through there. So what it has to do with, and you guys jump in if you think I'm way off base, but is the tumor implant biology. So we also did what's called polymerase chain reaction of blood after prostate biopsies. And after you biopsy a man with prostate cancer, you can detect very small quantities of prostate cancer cells cruising through the bloodstream. Polymerase chain reaction takes cancer cells and magnifies their the detection possibility. So if you have one cancer cell and you find it on polymerase chain reaction, you can magnify that cancer cell to see a signal to say, oh, yeah, there was definitely a cancer cell there. And then they go away. So we don't see spreading cancer in prostate cancer by biopsying it either through the skin or through the rectum. It just doesn't seem to seed it because of the way prostate cancer implants. It's different than other cancers. Have you ever seen a rectal cancer from the biopsy. So we see prostate, and the interesting thing is prostate cancer is adenocarcinoma, and most of the rectal and colon cancers are adenocarcinoma as well. So I know that's a concern. And some men said, I just could never have a biopsy because if I have it, you'll spread it everywhere. And with prostate cancer, it's just simply not true.
Thank you. How long after removal of a prostate should a patient expect a PSA test to establish a new baseline? That's a good question.
The answer to every question is it depends. That depends on how high the PSA was before the surgery. So it also depends on the sensitivity of the assay. The old assays we used to use would detect less than 0.1 nanograms per ml, but now the assays, the one we have at Eisenhower is so specific. It goes down to 0.008 or 8/1000ths of a nanogram per ml. So the half-life of a PSA is 6 weeks, or no, sorry, 6 days. So you have to take the number and go down every 6 days is going to go down by half. So to get down below 0.008, it generally, most of us will do, if the PSA is 10 or less, we'll generally check a PSA 3 months after surgery, most of the time at least. And then after that, it may sometimes if the PSA is 20 or higher, it may take longer than that. So we basically keep watching until it comes down. It should reach a nadir. And as long as it goes down, when it starts to come up consistently, then we know that it's nadired.
Oh.
But it's different depending on what the PSA was.
Thank you. Are you using AI to assess progressive risk or for any other purposes? This is a big topic, the use of AI in cancer care.
Not yet.
Thank you.
Hopefully soon.
So I have some patients coming from the primary care doctor who
Yes.
took their biopsy information, their PSA, their age, and put it in ChatGPT to say what are the recommendations. So it's really helpful. And I think it's an exciting advance as we start to get more and more data about prostate cancer. I think it will play a bigger role. But for right now, I think it's a pretty reasonable source of information for you to get as a baseline as you come in to talk to your radiation oncologist and your urologist about next treatment options.
I agree. I use ChatGPT to get information. What is clinical stage? Please explain. Someone did not understand what was meant by clinical stage.
I'll talk about it, but I'm so frustrated. So clinical stage used to be completely solely based on your rectal examination. And then people started using your biopsy results, if you had cancer on both sides, to say, well, now you're at what we would call a T2B. And now you have MRI. And so if the MRI shows that there's a nodule and you biopsy it, so clinical stage has gotten all messed up. And it's really hard today to decide what clinical stage is. Pathologic stage is more definitive. And you only get a pathologic stage if we take your prostate out. If we take your prostate out, they carefully step section through the whole prostate and they map out the cancer and tell us whether it's escaped the prostate or not. Is it in the lymph nodes or not? And then we have a pathologic stage. So clinical stage has become completely modified and dirtied. So there's no pure clinical stage left today. Pathologic stage is pure. But with clinical stage, we do talk about that. And there are some obvious clinical stages where we do a rectal examination, we fill out nodule, we biopsy that nodule, that has cancer. And then the MRI helps us, is the cancer out of the prostate or not? So it helps glean it, but the pure clinical stage used to be just your digital rectal examination.
Thank
What
you.
would you guys add to that?
No, for cancer, there's really just two stages. There's a clinical stage and a pathologic stage. Pathologic stage is if you have definitive oncologic surgery. So in this case, a prostatectomy. Anything else is the clinical stage.
Thank you. We only have time for a few more, and thank you for your patience, and thank you all. These are great questions, by the way. What prostate cancer cases are presented at the Eisenhower Prostate Cancer Tumor Board? How do you choose those cases? And what is a tumor board?
Go ahead.
Well, I mean, the tumor board is actually a meeting that includes all physicians in different subspecialties that treat prostate cancer or even for other cancers. So basically, there is a medical oncologist and there is a urologist and a radiation oncologist, in addition to possibly even other doctors, maybe the primary sometimes if they want to be there. So basically, the case will be reviewed in detail. And then we get into consensus really about how everybody thinks about his part of treating this patient, and everybody's connected to each other. That includes also the pathologist who reviews if he had any biopsy or surgery there, the radiologist who reviews the imaging in front of everybody, and basically putting 5 brains together to come up with a plan for that patient specifically. And we definitely have that tumor board once a month that we all attend and try to make the best decision for that specific case. Usually, we don't routinely add everybody. I mean, generally, for me, at least as a person, I add things that are not 100% typical, but definitely any case can be discussed.
Yeah, for urology, it's usually the really difficult case. So a patient who had rectal cancer and was radiated for the rectal cancer, now they have prostate cancer that's aggressive and needs to be treated. We would present that to find out, is he a candidate for additional radiation? What else should we be doing? For a patient who comes in and they've already decided, they're just absolute definitive, I want radiation or I want surgery, you don't have to present those cases at the tumor conference. Cases that are difficult, cases that are metastatic, maybe they got surgery first and then that failed and they got radiation and that failed. That's a great case that we would take to the tumor conference and say, okay, what should we do? We've got cancer in these areas. And so what's the next step so this guy does not die of prostate cancer? And then occasionally a patient will just come in and they've been all over the internet and they say, hey, I want my case presented at a tumor conference. I want more eyes on my case. And so we just present those cases as well.
Thank you. We have just 2 more questions. One is, there was an article in Healthy Living magazine just recently, it's Eisenhower's magazine. It mentions, is this agua ablation therapy for BPH? Are you aware of this? And
Yeah, that's a whole different topic, but that's aqua
Right.
ablation, yes,
Yeah.
which is for benign prostatic growth.
Okay,
So if you have symptoms from your prostate being too large, that's one of the treatment options, but that's kind of out of the field of our discussion tonight.
so I think part of what they're asking is this something that could perhaps be used for urinary incontinence after radiation?
The answer to that is probably most definitely no. That's caused by other factors. It's very incontinence after radiation is very complicated, but aqua ablation is not an answer for that.
Well, once again, this was exceptional. I thank you all. I thank you for being a wonderful audience and terrific questions.